Okay, thank you so much. First of all, I'm going to talk about imaging biomarkers. And first of all, I have to declare this conflict of interest. I'm scientific advisor for the tool that I will describe later. But I was involved also in the development of this tool. So why do we need assessment on fetal lung maturity? Well, we need assessment because we know that preterm, they have danger of neonatal respiratory morbidity. We know for sure in very early or very late weeks that they are in very high risk or very low risk, but we have a gray zone in the middle that the risk is still high, but not that relevant. And we are very interested in this bit of population because these late preterm are, they are 75% of the all preterm. So do we have a solution for this to prevent this respiratory morbidity? Well, we have the antenatal corticosteroids. We know that they improve respiratory morbidity for sure. In the short term, between 48 hours and 1 week, we know for sure that. But we know also that we need to avoid overtreatment and overexposition in these patients because we know the corticosteroids, they produce epigenetic changes, and we have a warning on long-term outcomes. And they are more important the most near-term these fetuses are. So the key question is, the key point is to get the right treatment in the right time to the right patient. Not to all patients at risk, but to the right patient. And I invite you to read this paper that puts all these things together and makes you think about all these questions. So it's possible to test fetal lung maturity by ultrasound. This is a very old question. I mean, this is nothing new. You can see in the slide that from 1980 something, they were trying to get information from the lung and by the scan to get information about the lung maturity. But in that time, I mean, the technique was the problem. And we were comparing with other tissues, placental or with the intestine or with the liver of the fetus. And we were getting some information, but actually this never went to the clinical practice. Later on, we improved the technique. There is a technique in ultrasound which is called quantitative ultrasound analysis that has been used for other things in medicine, just to test other tissues as the breast or the liver, and to see to check if a portion of this tissue if we could predict malignancy probably in these cases. So that was very logical to think that we could do something similar with the lung to know if this baby was going to have respiratory morbidity. But never these techniques, never these publications went into the clinical practice. So by that time, the only thing we need to test fetal lung maturity was the amniocentesis. We could get some amniotic fluid, and we could test phosphatidylglycerol or TDX or lecithin sphingomyelin or lamellar body count. But of course, we need an invasive test. We need to do an amnio. So are we in the point that we can test the scan, the ultrasound image, and get this information? Well, that's what we have been doing from 2007. That has been a very long way. At the beginning, we published that the image analysis was related to gestational age. Then we checked if this result was related to the result of the amniotic fluid that by that time we were doing to check fetal lung maturity. And then we could see in our center, in a small group of patients, that could predict neonatal respiratory morbidity, which is the thing that we are looking for, actually. So the big step was to do a multi-center trial and to validate this in, a more general population from different centers, different machines, different scans. And we made a multi-center study that we joined the efforts from 20 centers all over the world with the objective to evaluate the performance of this tool to predict neonatal respiratory morbidity in preterm and early term babies. So we did this prospective study that was multi-center and multinational, and we were obtaining ultrasound images from 25 weeks to less than 39. The image had to be taken within 48 hours of delivery, with no corticosteroids in between the image and the delivery. Of course, managing physicians were blinded to the results of the test, neonatal obstetricians and neonatologists. And we recorded the neonatal respiratory morbidity in terms of transient tachypnea of the newborn and respiratory distress syndrome. So we test the performance of the tool to predict this morbidity. We joined about 800 of images. Some of them had to be discarded because of the quality of the image, and we end up with 730 images. And we trained the system to analyze 2 windows of gestational ages, and you could see here that half of the patients were nulliparous, half of patients were Caucasian. That might be the population that you work with. And we had a small group of multiple pregnancies, and the reasons for delivery was a variety of reasons, but PPROM, preeclampsia, IUGR, and things like that we were planning or the delivery was expected. The gap between the ultrasound image and the delivery, as expected, was very short, was less than 1 day. And NICU and MISU, as expected, also was quite high, 33% of patients, because some of them, of course, were preterm. And we end up with a percentage of neonatal respiratory morbidity of about 13%. And you can see in the slide that in the group of late preterm, as expected again, the percentage of respiratory morbidity was around 5%, which is what has been published everywhere. Taking the whole group, we had a quite high prevalence of RDS, 66%, and 1/3 was transient tachypnea. So with this tool, we got numbers of performance of this tool to predict respiratory morbidity. And what is actually important is that if the test was positive, the basal risk could be increased. So you knew that this baby had higher risk of respiratory morbidity that you were expecting for the gestational age. And if the test was negative, that would decrease the real risk of this baby. So you could use this on your clinical practice. So these numbers are good or bad. Well, it depends on the comparison with the other tests. And you can see in this slide that compared with the other tests that we're using, the invasive tests, the numbers are quite about the same. Sensitivity was about 70-something%. Specificity was around 80-something%. And you see, that was comparing very favorable with the other tests, taking into account that the Quantus is a non-invasive tool. So what you need to do the assessment of the risk of morbidity, what you can do is to evaluate the risk of the preterm birth in a short term, within 7 days. revised indication for delivery, either induction of labor or cesarean section between 34 or less than 37 weeks, or elective cesarean section below 39 weeks, and be sure that you cannot or you should not prolong the pregnancy. That's a very clinical indication. We know that 25% of the late preterms, they have no real indication, not a formal indication for delivery. So we have to, you know, to revise the indication for this delivery. But if this baby has to be delivered, in any case, we can get information on the fetal lung maturity, and now we know that we can do this non-invasively. You can do a quantus, and then you can indicate corticosteroids only if needed, so you do not overtreat other patients. You can put all these things in your clinical protocol, which could be adapted to your, you know, to your clinical setting, and get a decision making much more homogeneous, which will be much better for your colleagues and for, of course, for the patient. And that's all I wanted to say. Thank you very much to all the team that helped us to develop all this tool. And that's everything. Thank you.